Hello, good afternoon and good evening, wherever you are joining from. Thank you for joining this Clinician webinar from the Clinician and Patient Education series. My name is Atul Deodhar. I'm a professor of medicine at the Division of Arthritis and Rheumatic Diseases in Oregon Health and Science University in Portland, Oregon. This program is brought to you by 4 different organizations: the Spondyloarthritis Research and Treatment Network, or SPARTAN, Group for the Research and Assessment of Psoriasis and Psoriatic Diseases, GRAPPA, the Spondylitis Association of America, or SAA, and the National Psoriasis Foundation, or the NPF. These are the planner disclosures, the people who planned this program, and these are our faculty disclosures. Here, what you're seeing is the accreditation statement and designation of credit for attending this activity. You're going to see this slide later again, but this is for the evaluation and CME certificate. So you don't have to write down this website, but we would definitely appreciate your feedback at the end of this program. So I will request you to take a few minutes at the end to complete the evaluation, and I'll show you this again for scanning the QR code or visiting the website shown there. Here is the agenda. We are first going to have pre-test polling questions. After the pre-test polling questions, and we won't show you the results immediately after that, Dr. Philip Mease will be speaking on psoriatic arthritis treatment updates, emerging data, and guidelines, followed by Dr. Joerg Ermann on the management of axial spondyloarthritis. You will have a chance to answer the same questions, post-test polling questions, and you will see the correct answer I'll reveal at that time. We are then going to hear the patient perspective about the treatment updates, and I'm delighted to say that Roz Tolliver and John Latella have joined us. We will then have time for panel discussion, and then I'll have closing remarks at the very end. So here are the pre-test questions. There are 2 questions, and I will ask you to answer them. You will be answering them directly. On your screen, you will not see the scores at this time. You are going to see them later on at post-test time. But this is a trial run for you. So here is question number 1. A 42-year-old male has had psoriatic arthritis for 10 years, manifest by polyarticular arthritis, enthesitis, and sacroiliitis, along with skin psoriasis. He is currently taking certolizumab after previous treatments with adalimumab and etanercept, which both worked for a considerable period of time, but then failed. Certolizumab has worked well for him over the last 2 years, but he's noticing breakthrough pain in each musculoskeletal area. Psoriasis is well controlled. He incidentally mentions that over the last 3 months, he has been experiencing diarrhea and occasional bouts of abdominal pain. He does not notice any blood in his stool. Which of the following options would you recommend for him at this time? A, apply for treatment with IV golimumab. B, apply for treatment with an IL-17 inhibitor. C, arrange for a GI consult to assess reason for diarrhea and abdominal pain and wait on the treatment choice until the results of his consult are known. Or D, apply for treatment with an IL-23 inhibitor. So you are going to now see those 4 choices, and please answer them directly on the screen. All right, we are going to go to question number 2. A 35-year-old male was diagnosed with ankylosing spondylitis 2 years ago and started on the TNF inhibitor. After having major symptomatic improvement initially, his symptoms have recently started to come back. For the last 3 months, he has experienced increased back pain and stiffness prior to the next injection. He restarted taking ibuprofen over the counter. What is the most appropriate next step? A, add methotrexate. B, prescribe a long-acting non-steroidal anti-inflammatory drug. C, switch to a different TNF inhibitor. D, switch to an IL-17A inhibitor. Or E, switch to a JAK inhibitor. Please answer. All right. Hope you had a chance to answer that question as well. So the first talk today is by Dr. Philip Mease on psoriatic arthritis treatment update, emerging data and guidelines. And I have the distinct pleasure of introducing Dr. Philip Mease, though he requires absolutely no introduction. Philip is the father of all psoriatic arthritis research in the US after he published his seminal paper on etanercept treatment in psoriatic arthritis way back at the start of the century. Philip is the clinical professor at the University of Washington School of Medicine, and is also the director of rheumatology research at Swedish Medical Center and Providence St. Joseph Health. Dr. Mease.
Hello, my name is Dr. Philip Mease. I'm Director of Rheumatology Research, Swedish Medical Center and Providence St. Joseph Health, and Clinical Professor, University of Washington School of Medicine. I'm delighted to have you here to hear about psoriatic arthritis treatment update, emerging data, and guidelines. The key approaches to treatment of psoriatic arthritis and axial spondyloarthritis include not only pharmaceutical treatments, but also an ongoing process of shared decision-making between the patient and the clinician. Education is a continuous process from the very beginning when the patient is having their diagnosis first made and all the way through as we talk about the progress of their disease and its control, as well as teaching about various treatment approaches. We want to focus in on what our goals of treatment are, and they may be slightly different between what the patient is focusing on and what the clinician is focusing on. So that's important to clarify. Families may want to get involved, including spouses or children or parents, and we encourage that to happen, including, for example, dialing in by cell phone during the midst of the clinic visit. We have to take into account the realities of the patient's life. Do they live far away, so it would be difficult to be treated with an infused medication? What is their financial situation in relation to access to some of the drugs that we use? And then, of course, there are many other clinicians that are often involved, including dermatologists and others that we want to communicate with to make sure that our treatments and treatment goals are accounted for by the various members of the patient's healthcare team. There are a number of non-pharmaceutical management approaches, including exercise, diet, and weight loss. And it turns out that weight loss is very valuable for management of psoriatic arthritis, both with diminishment of disease activity as well as with start of treatment, such as a biologic medication, a better chance to achieve goals of low disease activity or remission when the patient has lost some weight, and of course, physical and occupational therapy. These are the various clinical domains that we're trying to treat when we are treating with the pharmaceutical agents that we use, including skin disease, arthritis, enthesitis, dactylitis, spine disease, and then associated conditions such as inflammatory bowel disease or uveitis, and then taking into account comorbidities. For example, the poor woman on the right who has evidence of obesity and likely has hyperlipidemia and hypertension, which represent the metabolic syndrome. So we want to be addressing each of these types of issues when we are treating our patient. Here are the most recent GRAPPA treatment guidelines, and the way they're organized is by clinical domain. So peripheral arthritis, spine disease, enthesitis, dactylitis, psoriasis, nail disease, and taking into account the associated inflammatory bowel disease and uveitis at present. And instead of guiding the clinician through one treatment after another, trying to give a prominence to one type of therapy over another, what we do is we ask the question, is this treatment approach this particular class of medications efficacious in this clinical domain? And if so, let's include all of them so that depending upon the patient and their specific needs and interest, we can customize their therapy accordingly. So, for example, if a patient in the US is a Medicare population, then it's going to be probably a little bit less expensive for them to receive an infused medication. Or if the patient has a significant needle phobia, they may want to have an oral medication to use, and so on. And so what we do is we ascertain, is there adequate efficacy to put a medication in one of these boxes? As you'll see in a moment, when we get to axial disease, there may be more limited choices there, but this is a controversial area that I'm going to amplify on. And then, of course, we want to take into account any side comorbidities that the patient may have, which could contribute to side effects. So, for example, if the patient is quite obese and may have underlying fatty liver disease, they may have elevated transaminases, and if you treat with methotrexate or a JAK inhibitor, for example, there may be a problem with worsening liver toxicity. Or if the patient has a close family history of something like multiple sclerosis, then we might want to avoid a TNF inhibitor and so forth. So these are important considerations to keep in mind. The ACR guidelines are a little bit different in that they tend to guide the clinician more specifically. And one of the interesting aspects of the ACR guidelines is that they recommend use of a TNF inhibitor ahead of an oral molecule like methotrexate based on efficacy and safety. So let's get into this specific treatments. As you know, we're targeting specific cells and cytokines that are part of the inflammatory cascade. This cartoon from Chris Richland's New England Journal review of psoriatic arthritis highlights some of the key cells and cytokines that we're targeting and points out that some of them may have a different representation in different areas of the body. For example, synovitis may be slightly different immunophenotypically from enthesitis and skin disease and bone disease or the gut. And so we need to keep that in mind as we're choosing our therapies and looking at evidence for efficacy in each of these clinical domains when looking at clinical trial results. Here are the drugs that are either currently approved for the treatment of psoriatic arthritis or are soon to be likely approved. And I'm going to touch down on newer data with the medications that are bolded in this slide. I want to remind us that we might want to use targets of treatment. And here is an example of one that we use in our clinic. That's called the minimal disease activity criteria. If a patient has met 5 of these thresholds out of the 7, then they're in a state of minimal disease or low disease activity. If they've met all 7, then they're in a state of very low disease activity or remission. So these take into account not only arthritis, but also skin disease, enthesitis, but also patient global function and pain. Here's an example where we've used the MDA in a study in which methotrexate and etanercept were compared head-to-head. There were 2 etanercept arms, one with monotherapy etanercept and one with combination with methotrexate, and then there was a methotrexate monotherapy arm. If we look at the primary endpoint on the upper right, the ACR20 response at week 24, we see that there was a clear separation between the 2 etanercept arms and methotrexate. So this actually supports the guidance from the ACR guidelines suggesting that a TNF inhibitor might be superior to methotrexate. But note that the results with methotrexate are actually pretty good. And if we look over at the minimal disease activity we see that nearly 50% of patients in the etanercept arms have achieved this, and about 40% in methotrexate. So in situations where you must use methotrexate before a TNF inhibitor, this gives you some support for that. The other point to be made here is that there was really no difference between etanercept combined with methotrexate and etanercept alone. So it looks like monotherapy etanercept use is okay. By the way, this is in a very early disease population, just 6 months of median disease activity. Here's another study and which the MDA is again highlighted here. This was the primary endpoint at week 16 for this study, comparing adalimumab added to methotrexate 15 milligrams versus escalation of methotrexate in patients who had not achieved minimal disease activity on 15 milligrams of methotrexate alone. So what we are going to see in the next slide is the results at week 16 on the left-hand side. 41.5% of those patients that had adalimumab added to methotrexate achieved MDA, 58.5% did not. And I'm going to tell you about what happened to them subsequently. In the patient group that escalated methotrexate up to 25 milligrams, only 13% achieved MDA at week 16. And so it does appear that adding adalimumab is superior to escalating methotrexate. Interestingly, in the second 16 weeks of the study, one of the arms in the patients who had not quite achieved MDA when adalimumab was added, we intensified adalimumab treatment to weekly instead of every other week, as is the usual approach with this medication, and found that an additional 30% could achieve the state of minimal disease activity, and with not really any safety cost. There were not an increased number of adverse effects. So this actually gives us some ammunition for thinking about use of intensification of adalimumab to weekly. Now let's look at the IL-17 inhibitor class, and we're going to look at several of these. Here's a cartoon that shows IL-17 affecting a number of different cells in various tissues, leading to the inflammation and tissue damage that we know in the joints, the skin, and so forth. IL-17 is produced by a number of cells, including Th17 cells, but also other T cells, mast cells, and neutrophils. So it's ubiquitous and an important pro-inflammatory cytokine, just as TNF is. Here we see the results from so-called SPIRIT head-to-head trial, in which we looked at ixekizumab versus adalimumab. On the left is the novel primary endpoint of simultaneous achievement of ACR 50 and PASI 100, complete clearance of the skin. So a high articular endpoint and a very high skin endpoint. And more patients in the ixekizumab arm, 36% achieved this goal than adalimumab, 28%. In the ACR 50 response, they were similar. And this was projected that it would be non-inferior between ICSI and adalimumab. For PASI 100 alone, we saw that there was a greater response in the ixekizumab arm. So this supports the idea that the IL-17 class can be as efficacious as the TNF inhibitors in achievement of musculoskeletal responses and superior in the skin. Also, a number of other endpoints such as BLDA, MDA, other skin scores, et cetera, all showed improvement as well. And on the right-hand side, we see the adverse effect profile, which was consistent with each drug individually. So, for example, slightly more candida infections with ixekizumab, but more serious infections with adalimumab. And then there were one case each of ulcerative colitis and Crohn's disease with ixekizumab compared to adalimumab. Now, I want to show you just a bit of data from this trial out to week 52, in which it appears that the background use of methotrexate really didn't make any difference in the ixekizumab arm, but the adalimumab arm performed slightly better with background methotrexate. And now we're showing you results from a similar study that was done with the other IL-17A inhibitor, secukinumab, in which it was compared head-to-head with adalimumab. And I'm showing here a single outcome measure, the ACR 50 and PASI 100 response, and showing that it was similar to what we just saw with the SPIRIT head-to-head trial. So again, this is support that the IL-17s work well in musculoskeletal domains, similar to adalimumab and superior in the skin. One other important trial that has been conducted with secukinumab is shown here, and that is known as the MAXIMIZE trial. In this study, the patients were who had axial psoriatic arthritis, according to the investigator, were included in the study. And they looked at ASAS-20 response through week 12, which was clearly superior with the two different dose arms of secukinumab compared to placebo. This is the first time that a dedicated trial to axial psoriatic arthritis has been conducted. Typically, the way we have derived our evidence for effectiveness of a drug in treating the axial component of psoriatic arthritis is to use the ankylosing spondylitis trials as a surrogate. And so that's the way all the TNF inhibitors, for example, have been deemed to be effective in axial PSA. But this is the first effort to look at axial PSA only. One of the things that's quite interesting about the trial is that whereas MRI scans were done on everybody coming into the trial, it wasn't part of the inclusion criteria that you had to have abnormalities. And just 60% of the patients lit up on the MRI scan of their spine or sacroiliac joints, leaving 40% who didn't. And the graph on the lower right shows that even in the patients that didn't have MRI signal, that they responded just as well. Now, there's another member of the family of IL-17 cytokines in addition to IL-17A that promotes inflammation, and that's IL-17F. In a translational study, we see here that if we use a drug that has both IL-17A and IL-17F inhibition characteristics, bimekizumab, you see on the right of this heat map more green. And that means that there's more inhibition of expression of pro-inflammatory genes in that with that particular approach, as opposed to inhibition of IL-17A or IL-17F alone. Here is data that was presented at the recent EULAR meeting showing ACR responses as well as PASI 90 and achievement of minimal disease activity in a bio-DMARD naive PSA population, showing that this drug is effective. And 45% achieving MDA is quite a good result. Candida infection was seen in about 2.6% of the population. This was usually oral thrush. And it is that's an expected side effect from an IL-17 inhibitor. Here we're looking at a patient population that has already been exposed to a TNF inhibitor and being treated with bimekizumab. And we see similar results, not blunted results, as sometimes happens in a TNF IR population. And the same level of achievement of minimal disease activity. And in the pooled analysis for enthesitis and dactylitis, showing quite good results in the lower right-hand bar graph that's showing complete resolution of enthesitis and dactylitis. So when this becomes approved, as it is in other parts of the world, other than the US, we anticipated adding to the armamentarium of IL-17 inhibitors to be used. Now let's look at the IL-23 inhibitor class, and we'll touch down on two of these medications. Here is a cartoon which indicates the sort of role of interleukin-23. We're showing a dendritic cell at the gut lumen, and it's sensing the dysbiosis of the gut in a patient with psoriatic arthritis as kind of a danger signal, or just that. And we know that the microbiome in PSA is altered compared to normal. So in response to that, the dendritic cell puts out lots of interleukin-23, and interleukin-23 then travels and interacts with cells that have IL-23 receptor, such as MATE, NKT, ILC3, or gamma delta T cells, which are members of the innate immune system, resident immune cells sitting at various tissue sites, but also cells of the adaptive immune system, such as Th17 cells that have IL-23 receptor. And these, in turn, put out a number of different cytokines, such as IL-17, TNF, and so forth. Mast cells and neutrophils can also do this. And by this means, IL-23 serves as a very central pro-inflammatory cytokine. Here is data from phase 3 trial of guselkumab in patients that were bio-naive, showing you at week 24, 2/3 of the patients achieving an ACR20 response with the two different doses of guselkumab versus placebo. And then improvements in SHARP score on the upper right-hand side in the every 4-week dose, achieving statistical significance. And then in the lower right-hand bar, showing data on dactylitis and enthesitis showing improvement. Here we see skin responses, which are quite good, and we know that that's the case from the psoriasis trials with IL-23 inhibitors, which only have to be given every 2 months in the case of guselkumab or every 3 months in the case of risankizumab. And then we have here fatigue data showing improvement of this important clinical feature of inflammatory diseases, which is very important to patients. Safety-wise, the IL-23s are proving to be very good, with low rates of serious infection, no opportunistic infection like Candida or active TB, no inflammatory bowel disease, and very little signal in the way of malignancies. So this is really a very safe group of medications. Now, one of the questions that has arisen is because there was a failed trial of a IL-23 medication in treating ankylosing spondylitis. There was a trial with risankizumab. A sub-study was done looking at the phase 3 trials of PSA patients treated with guselkumab, who the investigators considered to have active axial psoriatic arthritis. About 30% of the patients had this, and they also had imaging evidence of sacroiliitis. So here are the results using a fairly objective outcome measure known as the ASDAS, which is used in trials of ankylosing spondylitis. And what was shown is that there was clearly a statistical separation between guselkumab-treated patients and placebo at week 24, and this was sustained out to week 52. So it's possible that there's enough difference between axial PSA and ankylosing spondylitis such that perhaps patients with guselkumab treatment may respond in axial PSA, but perhaps not in ankylosing spondylitis. This is being further explored through a trial of dedicated to axial PSA being conducted with guselkumab, and we're in the midst of that particular trial to give us further information about this. Here is data with the other IL-23 inhibitor that's been approved for psoriatic arthritis and psoriasis treatment, known as risankizumab, showing similar results as what we just showed with guselkumab. Lastly, I'd like to touch down on the JAK inhibitor class. And as you know, there's JAK 1, 2, and 3, and these are pairs that work at the receptor level on immune cells and are, with JAK inhibition, we are turning the stimulation of cells by a variety of different cytokines that are noted here. In red, we see cytokines that are directly downregulated through the JAK pathway, and in blue, IL-17 and TNF in particular. These are not mediated through the JAK pathway, but they are indirectly downregulated. And so we see a pan-cytokine reduction. Here is graphs from the tofacitinib trial in bio-naive population showing very good ACR responses as well as skin responses and improvement of function and radiographic non-progressors out to 12 months. Here we're looking at data with upadacitinib and focusing on the slightly lighter green bar, which is the 15 milligram dose, darker green 30 milligram dose, and maroon is adalimumab reference arm, gray is placebo. And what we're showing is efficacy of the drug in ACR responses, skin responses, and resolution of enthesitis and dactylitis. The approved dose of this drug is 15 milligrams a day. Here we're showing achievement of minimal disease activity, improvement in function, and change in inhibition of structural damage progression. Now, one of the issues with both tofacitinib and upadacitinib is, as members of the JAK family, they have this safety label related to the oral surveillance trial conducted with tofacitinib in a very large group of rheumatoid arthritis patients with high risk for cardiovascular disease. And there were slightly higher rates of adverse cardiovascular events, thromboembolic events, malignancy, and death in the tofacitinib arm versus etanercept adalimumab arms of the study in RA patients over the age of 50. So that has led to a label change where we need to use these drugs after a TNF inhibitor, as well as warning patients about this potential risk. There's a new pathway, though, that's being studied. This is with TYK2. This is there's JAK 1, 2, 3, but there's also this family member known as TYK2. And if you inhibit this, you are going to mainly inhibit interferon and IL-12/23. So one of the things that we can immediately see is if you inhibit IL-23, then maybe this will be potentially effective for psoriasis. Here's data from the psoriatic arthritis trial with this drug. And the cartoon on the left is highlighting the specificity of deucravacitinib by binding to the regulatory domain or the pseudokinase domain. It is the way it acts. And this makes it very specific for TYK2 inhibition and not JAK 1, 2, or 3 inhibition. Here we see positive results with ACR responses at week 16 in a phase 2 trial, improvement in function, enthesitis, achievement of minimal disease activity, and improvement of the skin psoriasis changes. Safety-wise, in this particular trial, there was no herpes zoster, opportunistic infections, or thrombotic complications. And testing of laboratory showed really very little, if any, change in hematologic parameters, cholesterol, or LFTs. There was a psoriasis program. Here's the phase 3 data showing very good efficacy. And in the chartreuse line is deucravacitinib, in the blue line is Primilast, a comparator, and then the gray is placebo. And these results were the basis for the very recent approval of this drug by the FDA in psoriasis. And interestingly, there was no black box warning. It doesn't have to be preceded by a TNF inhibitor, whereas the results of oral surveillance are described in the label, but they're put in the context of RA, which is not something that deucravacitinib is approved for. You don't have to be as concerned about the describing oral surveillance in full detail to the patient. Laboratory, one needs to monitor liver tests in patients that have risk of liver disease, but otherwise no routine lab monitoring is required. What do we do about patients who have tried everything? So I'm just leaving you with a few comments about that situation, which I know many of us face. And we are starting to experiment with off-label use of combinations of treatments. For example, putting together a relatively safe medication such as a Primilast or possibly an IL-23 or IL-17 inhibitor together with something that might have a slightly greater safety risk such as a TNF inhibitor or a JAK inhibitor. Indeed, there's a fascinating study that's currently underway in which the drug guselkumab is being used for treatment of psoriatic arthritis in one arm of the study, and then guselkumab plus golimumab, a TNF inhibitor, is used in the other arm of the study to look to see if this combination is A, reasonably safe, and B, might be more effective than guselkumab alone. And so either in our off-label experimentation in the clinic or through formal trials, which we're seeing coming forward, we're going to see, I think, more combination therapy use to try to get at some of the more recalcitrant patients. And hopefully in the future, we will be able, through these and methods, as well as new medications that are emerging, achieve low disease activity or remission for our patients and maintain them there. So we've gone through a number of different medication classes and their effectiveness. We've looked at new data with these. We've learned that we need to cycle through medications when one drug wears off in its effectiveness, and thus the need for many classes of medications and members of the class to be available to us. We've seen that we can achieve minimal disease activity state and suppress inflammation very effectively, including inhibition of structural damage progression. And this is something that is very, very good for us to be able to speak to about our patients and conduct a discussion with them through shared decision-making about what's the right medication for you. Thank you very much.
Thank you so much, Dr. Mease. That was a masterly presentation. Our next speaker is Dr. Joerg Ermann. Dr. Ermann is a professor at the Brigham and Women's Hospital, Harvard Medical School, and Dr. Ermann is going to speak on management of axial spondyloarthritis. Dr. Ermann.
Hello, I'm Joerg Ermann. I'm a rheumatologist at Brigham and Women's Hospital, and I'm going to discuss the management of axial spondyloarthritis. A number of organizations have published treatment recommendations for axial spondyloarthritis and ankylosing spondylitis. The two most prominent recommendations are listed on this slide. We have the recommendations from the American College of Rheumatology, the Spondylitis Association of America, and SPARTAN, the Spondyloarthritis Research and Treatment Network, which I'm also going to refer to as the North American recommendations. And then we have the ASAS-EULAR recommendations. ASAS is the Assessment in Spondyloarthritis International Society. The North American recommendations were first published in 2016 and most recently updated in 2019. The ASAS-EULAR recommendations were recently updated, and this update is about to be published. They have not been published yet, but the data have already been presented at a number of international meetings. On this slide, I compare the two sets of recommendations and show some commonalities as well as the major differences. Treatment with non-steroidal anti-inflammatory drugs and physical therapy is the first-line therapy in both sets of recommendations. Two different non-steroidals at full strength should be tried for 1 month before assessing the indication for second-line pharmacologic therapy. And it is at this point where the two sets of recommendations differ. The ASAS-EULAR recommendations require quantification of disease activity using a validated disease activity score for making treatment decisions. It used to be the BASDAI. In the 2022 recommendations, the BASDAI is replaced with the ASDAS, and the threshold is a disease activity of greater than 2.1 as the requirement for the initiation of second-line pharmacotherapy. The North American recommendations are less stringent, and they recommend initiation of second-line therapy if symptoms are unacceptably bothersome to the patient and judged by the examining clinician to be due to inflammation. A second major difference is the choice of the second-line therapy. In the 2019 North American recommendations, TNF inhibitors are favored over IL-17A inhibitors and tofacitinib, which was the only JAK inhibitor available at that time. In contrast, in the 2022 ASAS-EULAR recommendations, there is no hierarchy, and either TNF inhibitors, IL-17A inhibitors, or JAK inhibitors can be used. The next few slides provide some data on the drugs that we use to treat axial spondyloarthritis and AS. Most patients benefit from NSAIDs, although the response may differ substantially between patients, and individual patients may also respond differently to different drugs. Based on clinical trial data, there are no differences between the various NSAIDs. This is shown in this network meta-analysis. The only drug that performed slightly better than the others was etoricoxib, a COX-2 specific NSAID that is not available in the US. However, this drug was only used in a single randomized controlled trial. This study also showed that NSAIDs consistently worked much better for relieving back pain than morning stiffness, which I find quite interesting with regard to disease pathogenesis. Physical therapy and exercise are important in all phases of the disease. PT has been shown to improve well-being and function, and as discussed, PT should be part of the initial management of axial spondyloarthritis along with NSAIDs. In ankylosing spondylitis, physical therapy and regular stretching and range of motion exercises are important to maintain mobility. And of course, a regular exercise has many other health benefits. We have 5 TNF inhibitors that are approved for the use in ankylosing spondylitis in the US: etanercept, infliximab, adalimumab, golimumab, and certolizumab. There have been no head-to-head studies so far. However, comparing the outcomes in the individual studies, as summarized here on this slide, they all performed equally well with regard to axial symptoms. The same is true for the IL-17A inhibitors, secukinumab and ixekizumab, and the JAK inhibitors tofacitinib and upadacitinib. Again, no head-to-head studies have been performed at this time. However, the performance of these agents in clinical trials is comparable and similar in magnitude to the TNF inhibitors. In this situation, the major deciding factors in choosing between these drugs as second-line pharmacotherapy depends on 3 factors: on the presence of extraspinal disease manifestation and comorbidities, prior drug exposure, as well as access, i.e., availability of certain drugs based on the patient's insurance plan. Etanercept should not be used in patients with concomitant inflammatory bowel disease or frequent episodes of uveitis because of the lack of efficacy in these conditions. IL-17A inhibitors are significantly better in patients with severe psoriasis. However, they should not be used in patients with inflammatory bowel disease. And finally, JAK inhibitors have a black box warning for a potentially increased risk of venous thromboembolic events, major cardiovascular events, and cancer. And they have an FDA indication that includes the mandate to first use a TNF inhibitor before a JAK inhibitor. Certolizumab was the first biologic that obtained FDA approval for non-radiographic axial spondyloarthritis. And these are the results from the pivotal C-EXPAND study that demonstrated efficacy of the drug in this patient population. This study used a 50-week design that was mandated by the FDA. And in this study, drug was compared to placebo over the course of 52 weeks. And the study demonstrated clinical efficacy. The same was subsequently shown for secukinumab and ixekizumab, and most recently also for the JAK inhibitor upadacitinib in the SELECT-AXIS-2 study. So overall, the response of patients with non-radiographic disease and patients with axial spondyloarthritis has been comparable in all of the medications studied, providing support for a unified concept of non-radiographic disease and ankylosing spondylitis as being part of the spectrum of axial spondyloarthritis. However, there's an important point that I want to make here, and that is related to the study design of the studies in non-radiographic disease. So this slide shows data from the ABILITY-1 study, an early study in axial spondyloarthritis. And in this study, it was shown that the response to adalimumab was only present, or the therapeutic efficacy was only there in patients who had objective evidence for inflammation. In this case here, an elevated CRP level at baseline, whereas in patients who did not have an elevated CRP level, their response was not different compared to placebo. And the same has been shown for the presence of inflammatory lesions on SI joint MRI. Because of these findings, all subsequent studies, and that includes the 4 clinical trials that I showed you a minute ago, required that the enrolled patients with non-radiographic axial spondyloarthritis had to have objective evidence for inflammation, so either MRI, sacroiliitis, or an elevated CRP. And this is important also in clinical practice, because in patients with suspected axial spondyloarthritis who do not have objective evidence for inflammation, it is quite unlikely that they will respond to initiation of biologic therapy. A treat-to-target approach has been advocated for many rheumatic diseases, including rheumatoid arthritis, gout, and spondyloarthritis. The first study that tested this approach in axial spondyloarthritis is the TICOSPA study shown on this slide. TICOSPA meaning tight control in spondyloarthritis. This was an international study that involved 18 spondyloarthritis centers in France, Belgium, and the Netherlands. 9 centers administered usual care with follow-up visits every 3 months, and the other 9 centers applied a tight control regimen with monthly follow-up visits and medication adjustments using a predefined protocol and an ASDAS cutoff of 2.1 for making changes to the drug regimen. And the primary outcome of the study was the improvement in ASDAS health index at 48 weeks. This slide shows the results of this study. So there was a numerical difference. So there was a higher response in the patients treated with a tight control regimen, but the difference was not statistically significant. So does this mean that tight treat to target does not work in axial spondyloarthritis? Not necessarily. So there are two things that one needs to consider when looking at the data. First, several secondary endpoints, such as the ASAS-40 response, were in fact statistically significant between the two groups. And secondly, the control group in this study were academic centers with an interest in spondyloarthritis. And they assessed their patients every 3 months, which I believe is a reasonable interval for the assessment of axial spondyloarthritis after initiation a new therapy. So the control group in this study may have been better than just usual care. This is what the 2019 North American treatment recommendations say about treat to target and disease activity monitoring. So these recommendations recommend conditionally against the use of a treat to target strategy using a strict cutoff of a disease activity score over treatment strategy based on physician assessment. However, at the same time, regular interval disease activity monitoring is conditionally recommended. So what should we do in clinical practice? So there's a number of disease activity scores that can be used. First, the BASDAI, which is a very simple 6-question questionnaire that just takes a couple of minutes to complete, and the BASDAI can be calculated on the spot. A BASDAI of 4 or greater is typically used to indicate active disease, as in is often a enrollment criterion in clinical trials. The ASDAS is a more complex score. It involves 4 patient-reported outcomes, including 3 questions of the BASDAI questionnaire, plus in addition a CRP or ESR value as a measurement as an objective measurement of inflammation. The ASDAS performs better than the BASDAI and is the preferred disease activity score in the ASAS-EULAR recommendations. Drawbacks of the ASDAS include the need for a calculator and the fact that the CRP or ESR value is typically not available at the time of the patient encounter. Many rheumatologists in the US use the RAPID-3 score. This RAPID-3 score was developed for rheumatoid arthritis, but a number of studies have shown that the RAPID-3 also performs well in axial spondyloarthritis in AS and has a good correlation with BASDAI or ASDAS. So any of the 3 can be used to monitor disease activity in patients with axial spondyloarthritis. In contrast to these disease activity measures that largely rely on patient-reported outcomes, physical exam and imaging play a minor role in longitudinal imaging. In particular, there is no role for routine MRI or X-ray imaging. There's nothing that can be learned from worsening of the SI joints on a pelvic radiograph. And while the presence of syndesmophytes on lateral radiographs of the cervical lumbar spine has prognostic value, the repeat imaging should not happen more frequently than every 2 years because the development of these changes takes time, and more frequent imaging just exposes the patient to more radiation. So what if the second-line pharmacotherapy does not work? Here we need to distinguish between primary and secondary failure. In case of primary failure, it is first important to consider the validity of the diagnosis, and then it would make sense to change to a drug with a different mechanism of action. In contrast, in patients with secondary failure, it is recommended to change to a drug with the same mechanism of action. And in some patients, one can also consider dose escalation. In patients with secondary failure, it's also important to consider alternative explanations for the increase in symptoms, such as fibromyalgia, mechanical back pain, or a temporary flare of disease activity that would not require switching the drug. So what if the patient is doing well? What about tapering or withdrawing drugs? This question has been studied in a very controlled fashion in 3 recent randomized controlled trials. patients in this study with ankylosing spondylitis or axial spondyloarthritis who had achieved minimal disease activity were then randomized to either continue the drug or to switch to placebo, and they were followed for about 1 year. There were minor differences in study design between these three studies, but the overall message is the same. Patients that were randomized to placebo flared at a significantly higher rate than those who continued the drug. However, after 1 year of being on placebo, a substantial fraction, 20 to 50%, were still in remission. We currently have no reliable biomarkers to know which patients would remain in remission after switching to placebo or after discontinuing drug in clinical practice. We also don't know whether they would flare at a later time point because the time of these studies was limited. However, these studies certainly suggest that drug withdrawal might be worth a try in those patients whose disease is well controlled and who favor stopping their injection. Importantly, most of the patients who relapsed and resumed treatment thereafter regained control of their disease similar to their baseline level at the beginning of the study. One question that is often asked is, am I going to end up like this when patients see images of patients with severe ankylosing spondylitis on the internet? The scientific question here is, does our biologic therapy inhibit radiographic progression? And there are two aspects to this. One is radiographic progression from non-radiographic axial spondyloarthritis to AS, or the second question is radiographic progression in patients with ankylosing spondylitis. This systematic literature review compiled the data from a number of studies that looked at the rate of progression from non-radiographic axial spondyloarthritis to AS. And this review concluded that 10 to 40% of patients with non-radiographic disease will progress to AS over the course of 2 to 10 years, which is a very imprecise estimate. However, it also means that there's a high likelihood for patients who start out at the time of diagnosis with non-radiographic disease that they will not progress and develop ankylosing spondylitis. What about disease progression in ankylosing spondylitis? The disease course here is again highly variable. This is a study using old data from the OASIS cohort. So this is a cohort of pre-biologic era patients. And radiographic progression in the spine was measured using the M.C.S., which I'm going to explain in a minute. And the study showed a high degree of diversity in the rate of progression. The risk factors for rate of progression, or for radiographic progression, have been studied and are listed on the right here. So risk factors include male sex, HLA-B27 positivity, high inflammatory disease activity, for instance, a high CRP, cigarette smoking, and the presence of syndesmophytes at baseline. And this is the M.C.S., which is the standard score to quantify radiographic progression in clinical trials. The M.C.S. involves lateral radiographs of the cervical and lumbar spine, and the anterior corners of the vertebral bodies on these images are then scored, and the M.C.S. has a range from 0 to 72. The M.C.S. has been shown to be reliable, but it is not a very sensitive test, and a minimum of 2 years between imaging studies is required to reliably detect differences. This makes it impossible to conduct placebo-controlled clinical trials using the M.C.S. as a study endpoint. For the same reason, early clinical trials of TNF inhibitors compared radiographic progression in the patients treated with drug to a historical control group. And all of these studies failed to show a difference in radiographic progression between the TNF inhibitor treated subjects and the historical controls over 2 years. This cumulative probability plot shown on this slide here also demonstrate that the majority of patients in both groups did not have much MSS change over 2 years, which is a typical scenario in ankylosing spondylitis. Several observational studies over the last 1.5 decades have attempted to address the question of radiographic progression. This slide shows data from one of 3 systematic literature reviews that compiled those data, and they all came to the same conclusion that continued treatment for more than 4 years appear to have a small but measurable impact on radiographic progression. How can one think about this mechanistically? TNF inhibition may resolve inflammatory lesions without an immediate impact on new bone formation. Therefore, TNF inhibitors will have little impact on the growth of syndesmophytes that has already begun. However, by reducing inflammation, the initiation of new syndesmophytes is suppressed, which will then lead to reduced radiographic progression in the long run. In contrast to TNF inhibitors, there's much less data available on the impact of IL-17A inhibitors on radiographic progression. This slide shows the 2-year data from the MEASURE-1 trial of secukinumab, which suggested a more immediate impact on radiographic progression with IL-17A inhibition. However, the year 4 data looked much less promising and more like the TNF inhibitor data. The field is therefore eagerly awaiting the results from the SURPASS study. This study compares the effect of secukinumab with adalimumab biosimilar in ankylosing spondylitis patients with an increased risk for radiographic progression. So patients here had to have ankylosing spondylitis, but also either an increased serum CRP or at least one syndesmophytes on X-ray of the cervical or lumbar spine. The primary outcome of this study is the change in MSAS after 2 years of treatment. This is the first clinical trial that uses a radiographic primary endpoint, and it's also the first head-to-head study in ankylosing spondylitis comparing 2 different treatment modalities. Results of this study are expected for later this year. You may have noticed that I consistently spoke about IL-17A inhibitors rather than just IL-17 inhibitors. And this and the next slide explain why I think that this is important. IL-17 is a family of cytokines that includes 6 members, IL-17A through F. These are structurally related but have very different functions. This is particularly true for IL-17B, C, D, and E. So, for instance, IL-17C is produced by keratinocytes and not by lymphocytes like IL-17A, and is thought to be an amplifier of inflammation in psoriasis. There's also emerging evidence that IL-17D, which is produced by stromal cells and not by immune cells, may have a negative regulatory impact on inflammation. The 2 most similar cytokines in this family are IL-17A and F. These can form homo and heterodimers, so IL-17AA, AF, and FF. And the agents that we have available to block IL-17A have slightly different target specificities. So while secukinumab and ixekizumab only bind and neutralize IL-17AA and IL-17AF, bimekizumab also neutralizes IL-17FF homodimers, and the receptor antagonist brodalumab has an even wider spectrum. Recent clinical trials of bimekizumab and brodalumab in AS or axial spondyloarthritis demonstrated that these agents are effective in treating the axial symptoms of axial spondyloarthritis. It is at this point still unclear whether they are more efficacious than the IL-17A inhibitors, or whether they may have a higher rate of adverse effects, and this is something that needs to be looked at in more detail. There's still a lot of things that need to be learned about the management of axial spondyloarthritis. In addition to better tools for the early and precise diagnosis of the disease, we also need additional drugs for those patients who have an incomplete response to the existing therapies. The strategies to improve therapeutic responses may include also protocols for combination or sequential therapy, or interventions that target the gut microbiome, such as prebiotics or probiotics. And it would be desirable to have biomarkers that can help us in selecting the drug with the highest likelihood of success in the individual patient. So in summary, the treatment approach to non-radiographic axial spondyloarthritis and ankylosing spondylitis is largely identical. The JAK inhibitors tofacitinib and upadacitinib were recently approved by the FDA for the treatment of ankylosing spondylitis. So we have now 4 established therapies in axial spondyloarthritis: NSAIDs, TNF, IL-17A, and JAK inhibitors. A treat-to-target approach has not been formally shown to be superior to standard of care. However, routine disease activity monitoring is recommended. Physical therapy and regular exercise are important aspects of the management of axial spondyloarthritis. And finally, the primary treatment goal is suppression of inflammation and inflammation-related symptoms. Suppression of inflammation, however, likely reduces radiographic progression in the long run. And with this, I am at the end of my presentation, and I look forward to the question and answer session.
Thank you so much, Dr. Ermann. That was absolutely wonderful, state-of-the-art talk about the treatments that we have available and coming down the pipeline for axial spondyloarthritis. So now that our attendees have heard both the talks on psoriatic arthritis and axial spondyloarthritis, we are going to revisit the post-test questions. And as you know, these are the same questions, but this time I'm going to discuss the answers as well, and we'll show you what the answers are. So here is question number 1. A 42-year-old male has had psoriatic arthritis. I'm going to read this again so that you might have forgotten what the question was. 42-year-old male has had psoriatic arthritis for 10 years, manifested by polyarticular arthritis, enthesitis, and sacroiliitis, along with skin psoriasis. He's currently taking certolizumab after previous treatments with adalimumab and etanercept, which both worked for a considerable period of time but then failed. Certolizumab has worked well for him over the last 2 years, but he's noticing breakthrough pain in each musculoskeletal area. Psoriasis is well controlled. He incidentally mentions that over the last 3 months, he has been experiencing diarrhea and occasional bouts of abdominal pain. He does not notice any blood in the stool. Which of the following options would you recommend for him at this time? A, apply for treatment with IV golimumab. B, apply for treatment with an IL-17 inhibitor. C, arrange for a GI consult to assess the reason for the diarrhea and abdominal pain and wait for the treatment choice until the results of the GI consults are known. Or lastly, apply for treatment with an IL-23 inhibitor. So please vote on the screen directly and click, and we will wait for your answers to come in. All right. So here is the correct answer. The correct answer is C. And I am waiting to see what the answers were given. There we are. There we are. So 50% people got the right answer. Actually, the A, B, and C, the IL-17 inhibitor is in fact the wrong answer. If somebody has got diarrhea and abdominal pain, then one of the worries is that this person may have inflammatory bowel disease. So changing it to IL-17 inhibitor would in fact be contraindicated. If you change it to golimumab, which is another TNF inhibitor, that wouldn't be too wrong, or IL-23 inhibitor would not be wrong. But I think the correct answer is C. IL-17 inhibitors should be avoided in this situation. All right. Question number 2. Let's bring that up on our screen. This is a 35-year-old male was diagnosed with ankylosing spondylitis 2 years ago and started on the TNF inhibitor. After having major symptomatic improvement initially, his symptoms have recently started to come back. For the last 3 months, he has experienced increased back pain and stiffness prior to the next injection. He restarted taking ibuprofen over the counter. What is the most appropriate next step? A, add methotrexate. B, prescribe a long-acting nonsteroidal. C, switch to a different TNF inhibitor. D, switch to an IL-17A inhibitor. And E, switch to a JAK inhibitor. Please vote. All right. We are back again. And again, the correct answer is C, switch to a different TNF inhibitor. And let's see how people have voted. And the reason the C is the correct answer is because this patient has had TNF inhibitor for a couple of years and he did very well. The 2019 ACR SAA SPARTAN treatment guidelines suggest that in patients with secondary failure of TNF inhibitor, and this is a classic case of secondary failure is the patient has done remarkably well for 2 years. And after 2 years, it is now not working very well. If that is the case, one can go back to the same class of drug. Here it is TNF inhibitor. And that's why C is the correct answer. 33% got it correct. IL-17 inhibitor is also not too bad, but we have limited choices. And that's why we try to conserve our drugs. Thank you. So we are now going to hear the patient perspective from two patients, Roz Tolliver and John Latella. And before I introduce them to you, I must say that I have had chance to present another webinar with them, and I was highly impressed how inspirational their stories are. And you're going to hear two very inspirational stories from these patients who live with these diseases. They are both amazingly well informed. They are amazing advocates. They're great advocates, not only for themselves, but also for other patients. So the first would be Roz Tolliver, and Roz is a 57-year-old teacher, wife, and mother from California. Her diagnosis of ankylosing spondylitis was delayed for nearly 30 years, despite her numerous symptoms and strong family history of the disease. Today, Roz manages her condition with a variety of medication and medical devices, as well as daily exercise and recreation. And since her diagnosis in 2018, she has volunteered as an advocate for herself and the others with ankylosing spondylitis by leading support groups, serving on patient advisory boards, and also participating in awareness projects. Roz, the floor is yours.
Thank you, Dr. Deodhar. Hi, everyone. As you mentioned, my name is Roz Tolliver, and my life with ankylosing spondylitis has been a roller coaster that I got on. It's been 45 years now. I was 12 in 1977 when I was diagnosed with lung inflammation and persistent neck and shoulder pain. And then at 16, I started getting unexplained chronic fatigue and fever. And then later I was in the Navy in my early 20s when I started getting chronic back and knee pain with stiffness. My flares were not frequent then, and because I was young, I bounced back quickly. And the treatment back then was bed rest, narcotics, and at that time it was mostly passive physical therapy where they did things to me. I didn't do any activities. And then over the next 30 years, I developed a variety of symptoms all over my body, particularly chronic pain and inflammation in 8 peripheral joints, from my shoulders to my feet. I've also had inflammation in my eyes, lungs, esophagus, and stomach. And my treatment during this time started to get really expensive out of pocket, and included NSAIDs like ibuprofen for the inflammation, and then a variety of narcotics for the pain, more physical therapy, chiropractic care, massage therapy, a TENS unit, braces, steroid injections, several different pain management procedures in my back, and 10 joint surgeries. Now, despite all of these symptoms and a strong family history of SPA, I wasn't diagnosed until 2018. For years, I would tell my providers, that my father had it and his spine was completely fused and he was legally blind from chronic uveitis, and also that my brother had SPA and ulcerative colitis, so that, these providers would check me for SPA. Now, unfortunately, they believed that the diagnosis hinged on my being positive for the HLA-B27 gene, and I'm negative. So the doctors I saw believe that you could not have one without the other. So some providers would just treat the isolated symptom I saw them for, but then others tried to make a connection between my symptoms. So one doctor diagnosed me with fibromyalgia, but the treatment for that didn't resolve my joint pain or my fatigue. And then others misdiagnosed me with lupus and rheumatoid arthritis, and none of them ever referred me to a rheumatologist. So after 30 years of wondering why I had so many chronic health problems all over my body, it was a nurse practitioner who suggested I see a rheumatologist. And since I believed that I had AS, but I knew that my negative HLA-B27 status was an issue, I did some research online and discovered that about half of African Americans with SPA are negative with HLA-B27. So I then referred myself to a rheumatologist, and he diagnosed me within weeks. And I was so relieved that some family and friends could no longer call me a hypochondriac that I cried in the parking lot afterwards. And the rheumatologist put me on a biologic immediately because of my delayed diagnosis and active disease. And it was the first time that I was given a medication to prevent my symptoms. And it worked on my fatigue right away. And fatigue was my worst symptom, really. Now, besides my biologic, I also manage my disease with what's worked the most over the years. So a lot of topical medications, braces, staying active physically and mentally, listening to my body and resting when needed, and then getting emotional and physical support whenever I start to struggle. So my life with spondyloarthritis is in a word, bittersweet. On one hand, I'm trapped in a painful, unpredictable body that hampers my ability to earn a living, work full time, and do many things that I once enjoyed. And I did have trouble coping for those reasons. So I got counseling to help me accept my new normal. Now, on the other hand, I'm fortunate that my daddy taught me how to keep going in spite of pain and limitations, and find new hobbies to replace the ones that I could no longer do. And he didn't know he was teaching me this because he died 10 years before I got diagnosed. But I've gone through hell with this disease, but it's made me much more resilient. And I've met wonderful people like the people in this group that I wouldn't have otherwise. All right. Well, thank you for your time, and I'll pass it back to you, Dr. Deodhar.
Thank you so much, Roz. That was an amazing, inspirational stories. And I can see how mistakes were made at every stage. We know that women get delayed diagnosis, and being an African-American woman and B27 negative, I can see how every step the providers, unfortunately, were confused, and you didn't get the correct diagnosis. But it is inspirational to me how positive you are and how you have turned this whole thing around. So the next patient who's going to be presenting is John Latella. John is an 80-year-old gentleman living in Connecticut and was diagnosed with psoriasis in 1964 while he was on active duty in the military. And 12 years later, when he was in civilian life, he was diagnosed with psoriatic arthritis in 1976. He receives his treatment currently from the VA and has been through just about every treatment available. He has been with the National Psoriasis Foundation since 1985, and he serves as an advocate and a mentor. He serves on the board of the International Dermatology Outcome Measures, or IDIAMs, as the patient research partner since 2013. And in 2016, he joined GRAPPA also as a patient research partner. So here is another inspirational story from another patient. John, the stage is yours.
Good afternoon. My name is John Latella. When I was 34, I was diagnosed with psoriatic arthritis. I really didn't have any symptoms other than the fact that the VA wanted me to go through this extensive diagnosis. I spent 4 hours at a VA hospital in Providence, Rhode Island, going through a lot of x-rays. And in those days, x-rays took quite a while to develop. That's why the time was so long. And for a long time, I really didn't have any medications. I really didn't even know what psoriatic arthritis was. I couldn't get on the internet because there wasn't any. Over time, I think more of what I've done is personal. The one thing I did after I was diagnosed in 1979 is I quit smoking. I quit smoking because I had bronchitis. And my PCP said, "You want bronchitis next year, keep smoking." I went home and I quit smoking cold turkey. And I had nicotine withdrawal for at least 2 weeks. It wasn't the most pleasant thing to go through, but I think it was the best thing that I ever did in my life. Well, as I went through time with the psoriatic arthritis, about the only thing that the doctors would recommend I take was Tylenol to reduce the pain. But in 2005, I went to a conference with the National Psoriasis Foundation had in Chicago, and they had a presentation on biologics and what they could do, how much they could stop the progression of psoriatic arthritis and help with psoriasis. I went back to the VA that same year, 2004, and asked if I could get on one of the biologics. I said, well, the FDA hadn't approved it yet for psoriatic arthritis. As soon as they do, we'll let you know. Well, the next time I went back to the VA, which is every 3 months, they said it was approved, so I said, can I go on? I went on the first biologic, and it cleared my skin 80% in 45 days. And it seemed to stop the progression of psoriatic arthritis. I wasn't as achy as much. I could move rather fluidly. And that was in 2005. I've been on, in 2006, the first biologics I was using stopped. And I was getting flares back from psoriasis. So they switched me over to another biologic, which I've been on since 2006. So total biologics I've been on 17 years. I have not had any side effects. It hasn't, and I continue to take it. I can see after the period of time that I take it, when I get to the point where I'm going to take it again, I can feel a little bit of, not anxiety, but achiness in my body with the psoriatic arthritis. I think it's very important for patients to ask their dermatologist to refer them to a rheumatologist to determine whether they have psoriatic arthritis or not. I tell patients that I work with that I have nails that are grooved. My toes are like sausages. And these are two indications of psoriatic arthritis. And if you think you have anything like that, and you have psoriasis or psoriatic disease, go and get tested. It usually takes x-rays. I don't believe, I may be wrong with this, that there's a blood test that you can identify psoriatic arthritis yet. I mean, there's one to come, I'm sure. But be proactive. Don't decide you'll wait and see. Doesn't help to wait and see. You don't want deformed fingers. I've seen people with deformed limbs. Sausage is just worse than mine. So just you have to learn to be proactive and take care of yourself. I appreciate the time. Thank you.
Thank you, John. Thank you very much for another inspirational story of how your condition was diagnosed and what all you have gone through all your life. And it is it really is inspirational when I meet patients like you in my own practice. We are going to move on to now Q&A and discussion, and I am looking at the chat here. So the very first question, I think, is for Dr. Mease, and it says, what are the differences, clinical or radiological, in the axial involvement of patients with psoriatic arthritis as opposed to axial spondyloarthritis and other conditions? So they just leave it open at other conditions as well.
Sure.
Dr. Mease?
Sure. Thanks, Atul. And that's obviously a very good question. So there are some very important distinctions. For example, many patients with psoriatic arthritis, instead of developing their spine element of their psoriatic arthritis in their late 20s or early 30s, will do so later on in life. So it might be late 30s, 40s, 50s even. And they might have had their psoriatic arthritis condition in the peripheral joints, like hands and feet and the enthesitis and so on, for years before the spine disease develops. So what does that create as an issue for us when we're trying to sort it out? Well, about the same time in life, many of us start developing achy backs from degenerative arthritis changes. And oftentimes when x-rays or MRI scans are taken, the radiologist and the clinicians, like the orthopedist or that are being consulted, or the primary care docs, they'll look at those reports and say, oh, there's a bunch of degenerative arthritis that's being commented on by the radiologist, so that must be the reason for their pain, without thinking about the possibility that hidden in there could be inflammatory changes of the bone and the joints and the entheses that due to psoriatic arthritis. And so sometimes it takes either a change in the therapy that you're doing for psoriatic arthritis, or stepping up into biologic therapy for the first time to really get effect in the spine. Some of the features that we look for, for example, the sacroiliac joints that we've been focusing on a lot at the base of the spine, right where the pelvis meets the spine. In axial spondyloarthritis, it's typical for both of those sacroiliac joints to be equally involved. But in psoriatic arthritis, interestingly, and especially those with a gene marker known as HLA-B8, may have it only on one side, and the other side will be completely normal. Or up in the spine, the person may have not much involvement of the lumbar spine, but significant involvement up in the cervical spine in axial PSA, psoriatic arthritis. Whereas in axial spondyloarthritis, it tends to sort of start in the lumbar spine and sacroiliac area, and then may go up the spine later on, but it tends to be more involved in the lower part of the spine. Also, many patients with axial PSA may have no symptoms. We may see evidence of it on imaging, but their symptoms for some reason are relatively quiescent. So I could go on, but there are other important, like for example, when we look at the calcium bridges that form between the vertebral bodies, they actually look different in people with psoriatic arthritis. They look kind of chunky and enlarged, whereas the ones in axial spondyloarthritis are really slim and not chunky in appearance. So it's very clear to us that there's something going on that is a little bit different about the axial involvement in PSA, and all the more reason for us to really think hard and work our hardest to try to make a proper diagnosis.
Yep. Thanks, Philip. And if I may just add, I mean, for the providers who are in the audience and attending, is that we are currently involved in two very important studies. One is the AXIS study, which is a combined study between GRAPPA and ASAS to basically get the natural history of the disease, even to set up the classification criteria, what we call as axial PSA. And the second study, of course, is looking at whether IL-23 inhibitor guselkumab really helps in this population by looking at the imaging data to see whether it really helps. Philip presented the data showing that IL-23 inhibitor at least in the earlier 2 studies, phase 3 studies, did show that there was some evidence it improves ASDAS and BASDAI. What we didn't look at that time was whether MRI changes as well. So thank you. So, I mean, basically that is just going to, these 2 studies are also going to throw some more light. There is a question about IBD-associated arthritis, and maybe Joerg can answer this. The question is, what is the treatment approach for axial involvement in IBD-associated arthritis? Is there any research in this area, or the treatment options extrapolated from AXPA studies? Joerg?
Yeah, it's a very good question. There are no clinical trial data for patients with IBD-associated spondyloarthritis, and so we do extrapolate from psoriatic arthritis for peripheral disease and the trials in axial spondyloarthritis or AAS for axial disease. Whether this always works or whether this extrapolation is justified is an open question. It's a very similar question to what Dr. Mease and Deodhar just discussed, whether the axial involvement in psoriatic arthritis is the same as in AS. And one can ask the same question here: is the axial disease in IBD spondyloarthritis the same as in AS? And we also have many patients with imaging changes that do not have axial symptoms. So just one additional point, it becomes more complicated in those patients with axial spondyloarthritis and IBD because we have not a lot of options. And it depends also a little bit on whether they have Crohn's disease or ulcerative colitis. So the IL-17A inhibitors are out, as we discussed. So we have the TNF inhibitors. And then fortunately, there is benefit from at least upadacitinib in inflammatory bowel disease and possibly also in Crohn's disease, whereas tofacitinib does not work in Crohn's. So the options in IBD-associated spondyloarthritis are limited, and there is a need for more research. And I think there's also an increased appreciation both in the spondyloarthritis and in the IBD field that more research in this area is needed.
Yeah, great. Thank you.
Atul, if I could add some comments.
Yeah, please.
So this is an area that is really interesting in that it's kind of like the working together between dermatologists and rheumatologists in psoriatic arthritis and psoriasis. Similarly, there's a close relationship between gastroenterologists interested in IBD treatment and rheumatologists. So I actually have on my cell phone, I could show you the speed dial for the main IBD gastroenterologist in my area in Seattle and the nurse practitioners that work with them, because we're constantly on the phone with each other. Yesterday, I was talking to the nurse practitioner for a patient that she had just sent over, where she had the gut disease well controlled with the drug adalimumab, but she was having significant inflammation, pain in her musculoskeletal system, in both the peripheral joints and the spine. And so we sort of stewed over it for a while, and ultimately we decided just simply to try a different TNF inhibitor to see if it could better cover both. But one of the other things that has been very interesting in this relationship I've found is, and this is an off-label comment, but we'll have the gastroenterologist say prescribe one drug that works really well in the intestinal inflammation, but not so well in the musculoskeletal, whereas we will, as rheumatologists, prescribe something that works well in the musculoskeletal system. And in this way, we can sometimes optimally control both. For example, there's a medicine called vedolizumab that works just for the gut inflammation, but not for the musculoskeletal. And then we might use along with it another biologic medication that works well in musculoskeletal. So it's an example of the teamwork that can go on between two disciplines.
Thank you. There is a question which has come for Roz and John, and this is from a nurse in rheumatology practice. And I guess it's a nurse practitioner. It says that are there any suggestions or recommendations for education or information that allied health professionals could offer in a rheumatology practice? And I want to combine that with another question that came earlier. And this was about, and this probably came from a patient, and they asked as to where should I go for improving my understanding? And so the exact question was, what should I do to help gain a better understanding of my disease? And how should I stay informed? So whoever was listening to John and Ross, they were pretty impressed as to where did you guys get all this information? How did you start your collecting of the knowledge? So maybe Ross, you can start.
Sure. So for the last question there, get educated any way that you can. The easiest way is through the internet. Everything is at your fingertips. All of the foundations that you mentioned, Dr. Deodhar, at the very beginning, for me, it was the Spondylitis Association. And then, of course, if you have psoriasis on top of that, you got the National Psoriasis Foundation. But you can just Google the disease. You can put in ankylosing spondylitis or the super long name, the Axial Spondyloarthritis or whatever. And there are zillions and zillions of articles. I would be really careful about what you read, though. You want to pick a website that's like maybe a nonprofit dedicated to educating patients, rather than, some of the other sites. Sometimes it might be a chiropractor or something trying to sell you on things. So you have to be careful where you get your information, but try to learn as much as you can online. You can also try social media. There are tons of groups dedicated to our disease on Facebook and Tumblr, Instagram, Twitter, you name it. They all have groups set aside. So that's one way to do it. The first question, and I'm trying to remember now the details.
How can a nurse practitioner or allied health professional help? Or what can they do to offer some more education or information to patients?
Well, like I mentioned in my story, it was actually a nurse practitioner who told me about going to see a rheumatologist. I found that my nurses, and when I see a nurse practitioner or physician assistant, that they usually have a little more time. They'll ask more questions about things. And that's how the nurse practitioner I saw was able to connect certain things that maybe the doctor wouldn't. So getting educated yourself about some of the things to look for. If you get somebody who's constantly coming in and they have I had all these different joint issues, shoulders, elbows, knees. If you, think about it as you're, checking them in, doing the blood pressure and thing, if you can ask them, you ever have any issues with your eyes or issues with your feet, things like that, maybe that would be information that you could pass along to the doctor. So that would be my suggestion, is just to get educated yourself.
Yeah, thank you. And I think the caution that you said earlier is so very important. I mean, one can go on the internet and one can go on these things, but then you might end up into somebody who's trying to sell you some drug or trying to sell their services. So nonprofits. Yeah,
I don't know if you heard, there's a cure for $69.99. There's a cure. So.
Exactly. Stay away from that. I think National Psoriasis Foundation, Spondylitis Association of America, American College of Rheumatology, Arthritis Foundation, these are pretty good resources. John, do you want to chime in? Do you want to tell us how you got all your information and how did you get?
When I was first diagnosed in 1964, there was no internet. There was no Google, no Microsoft. And I was at a loss. I asked the doctor, what is psoriasis? On board ship, this is. What is psoriasis? And he said, I don't know. Well, how do I treat it? I don't know. So I was on my own. I did go back to the shore at the Naval Hospital in Richmond, outside of Norfolk, Newport News. And there was a dermatologist that had more knowledge. And of course, there was a first-class petty officer that gave me his interpretation of the disease, which I cannot state over this television or Zoom call right now. It didn't come to me until after the internet came into existence. And but in 1985, I relied mostly on the National Psoriasis Foundation. They gave me more information than I could get anywhere else. And then as time progressed, I went to the internet. And like Roz was saying, I'll be very careful of the sites on the internet. If I couldn't find 3 sites that all agreed and weren't promoting something, I just dismissed them. As far as how a clinician could find more information about it, ask a patient. Sometimes the patient has the knowledge that they can give you, can pass on. We're here. We live with the disease. Don't think you're infringing upon our I can't think of the word right now, on our person. Just ask us, and we'll be glad to tell you what we found out and where we found it out, and it will help you.
Thank you. What you're saying is one has to be their own advocate, and you and Ross both have been your own advocate very well. Thank you for that. There is a question about biosimilars, and maybe I should ask this to Joerg, because so the question is, are there huge differences between biosimilar and the branded biologic? And if there is not, why did the 2019 ACR SPARTAN treatment guidelines, SAA treatment guidelines suggest that we should not be going to biosimilars, or exactly what is the wording there? Can you explain that, please?
Well, so the definition of biosimilar is that they're equally effective and that they work the same as the original molecule. The 2019 recommendations have a very specific wording here, which is a recommendation against a mandatory switch, not a switch per se. So I was not part of the panel that generated that, so I cannot really, I don't have all the insights on what the discussions were. But I think the main point here is a recommendation against a mandatory switch, that everyone has to be necessarily be switched. Otherwise, I think there is no. I think that there is no real argument against switching to a biosimilar.
You're absolutely correct. I was on that panel, and you're absolutely correct to say that the wording says that mandatory switching should not be done. There is always this shared decision making, and patients do get upset when suddenly they start getting a different drug. And then some patients say that they're not going to respond to this, and it is our job as providers to educate them and get them into confidence, explain to them that biosimilars have been looked at, studies have been done, and it is meant to be very similar in efficacy, exactly as you said. And it should not be done behind their back. That's exactly what the guidelines say. They are not really against biosimilar as such. There is a question for...
By the way, Atul, if I could just throw in a comment, I would like to concur and underline what you've just said. The biosimilars are coming. There's no way around that, and it's going to reduce the cost, for the most part, of these medications, and potentially may improve access to them, with more of these becoming available and to a broader swath of the population. And I've been impressed by looking at the studies to see just exactly how similar they are, as Joerg was just explaining. They are very much like the originator compound, and they're being made by very reputable companies for the most part for the biosimilars that will be available in the United States. So I really want to reassure people listening that I think that this is going to be fine, and agree wholeheartedly with Atul that it's important to educate your patients about this and then have them participate in the decision to allow a change to occur.
Yeah, thank you. I'm afraid we have gone up over our time by a significant amount, but there are two important questions which I'm going to pose, one to Philip and one to Joerg, and both of you can also jump in after that, and then we will probably end because I got a few other announcements to make. The question to Philip is about combination therapy. Can you speak a little bit about combination therapy and combining anti-cytokine therapies, and where we are, and are we going there or not? And so tell us.
How much time do you need for this?
I'll try to be crisp. So the answer is yes. We're going there, and I feel like in a lot of ways rheumatologists are becoming more like cancer doctors. We're going to be in an era where we can really do more precision medicine, target specific therapies based on patients' genomic and proteomic and metabolomic patterns and their immunophenotype. And I think we're going to get better at what we do over time. And some of that's going to involve putting two medications together or more. And some of that is going to be using two different medications, say a TNF inhibitor and another medicine like PDE4 inhibitor that we know is pretty darn safe, and so could be most likely safely combined with the TNF inhibitor. A little tougher when we've got a couple of these choices where they both have a little bit more in the way of serious infection risk. So then we have to think a little bit more carefully. But we're also going to see some novel medications being created where that you put two different mechanisms on the same molecule. That's really cool. And so I think there's a brave new world out there coming along where for those of you who are working with patients where you've tried everything, in quotes, and need something to move to. And by the way, there's a trial underway where with one particular approach where they're putting an IL-23 inhibitor along with a TNF inhibitor, two different medications versus just the IL-23 inhibitor in psoriatic arthritis to see how well it does.
Thank you. Joerg, you want to chime in about?
Yeah, I agree. It's a very interesting field. And, the question is how these trials are going to be done, because, how many patients do you have available to actually do the studies? Are there more pragmatic ways for doing the studies? And the other question that's related to this is how would this in the long run work with cost? So, for instance, would a combined therapy be available at a price similar to a single drug? Or are there ways to, for instance, do an induction protocol followed by a maintenance protocol with just a single drug? So a lot of ideas, I think, that are out there and a lot of work that needs to be done.
Yeah, I want to chime in myself as well. When this question is asked to me, I give two examples. One is, of course, bimekizumab, which is combining and blocking IL-17A and IL-17F. But even more important is we are already doing it by giving people JAK inhibitors. And Philip showed that very nice slide of how JAK inhibitors work. And JAK inhibitors do definitely block multiple cytokines. I think we were quite lucky that multiple cytokines being blocked by JAK inhibitors, we did not have significant side effects that one would worry about blocking 2 or 3 cytokines. And clearly JAK inhibitors are doing it anyway. And so we are already there. We are already blocking many cytokines, and it's a kind of combined blockage of cytokines. The last question is, and this is another opening can of worms, Joerg, how do you manage non-radiographic axial SPA patients who do not have clear evidence of inflammation? So they don't have elevated CRP or sacroiliitis on the MRI. Do you still trial biologics if they do not have adequate response to non-steroidal and physical therapy? Or you just wait for and continue to monitor radiographic changes?
So I try to address that in my presentation. So the early clinical trials in axial spondyloarthritis showed that patients who do not have objective evidence for inflammation, did not do better than placebo. So from that perspective, in a situation like this, there's a high likelihood that if the patient gets on a biologic, that there will be no response. I personally don't think that the lack of a CRP elevation or MRI findings should preclude the use of biologic if there is enough evidence that the clinician is, that the clinician thinks that the diagnosis of axial spondyloarthritis is correct. I think it's important in that situation then also to discuss with the patient what the expectations are, which is that, we can try this, But then after a certain period of time, we will assess the response and then make a call. And I think the uncertainty of the diagnosis needs to be discussed with the patient, and then I think it would be okay to actually embark on a trial of therapy with the biologic.
Philip, what is your approach for somebody who's CRP negative, MRI negative, non-radiographic axial SPA? Would you try a biologic?
The answer is yes, but I would echo exactly what Joerg said. I would want to have a strong suspicion that this is really true inflammatory disease and not a patient with another diagnosis where it seems to mimic it. And so you get a spidey sense when you've been around doing this work for so long about that. So there's some patients where I feel very comfortable about trying this, and I can trust that they're going to give me pretty accurate feedback on the results. So that's you really have to have a good clinical judgment in making these decisions, because these drugs don't come without some risk.
Yep, I completely agree with both of you. I think the studies and sort of things that you see at a group level may not be at the individual level, and we always have to try. If you're convinced about the diagnosis, then yes, I would also try using a biologic if I'm convinced this person has it, and then after some time, with a set amount of time, we would probably withdraw it.
I just want to add one sentence or two. So the suspicion or the diagnosis of non-radiographic disease should not be based on a positive HLA-B27 and chronic back pain. That is the most important thing, because those patients then very often do not have the disease. But if there's other evidence like extra spinal disease manifestations, positive family history, and this kind of thing, I think that increases the likelihood that the diagnosis is correct.
Excellent. I think all good things have to come to an end. I'm going to share my screen here because I think we'll have to move on. We definitely would like to hear from you the evaluation of this program. So to receive a CME certificate for this webinar, please complete the evaluation, and you can do it by visiting that link that you see there. You can also scan the QR code. So you can click on the link in the menu. You can click on the link in the post-event email that you will get. You can scan the QR code, but please do evaluate, and then that will give you also to tell you how to get the CME certificate. And join us for the Treatment Update podcast. So the patient podcast, Treatment Choices for Psoriatic Arthritis and Spondyloarthritis, is already available for a couple of days since October 18th. And the Clinician podcast, the Psoriatic Arthritis and Spondyloarthritis Treatment Update, will be available. Release date is October 20th. And so these are the upcoming patient webinars and podcasts. Encourage your patients to join the final CAPES patient webinar and podcast. Does changing health behaviors help your arthritis? So we are going to speak about the lifestyles and the myths and the solution. And the patient podcast release date would be November 1st. And the patient webinar on this subject will be November 3rd. Thank you all for attending today's program, and I hope you have enjoyed it, and have a very good evening.